She held various positions as a assistant professor, consultant psychiatrist in Bhopal, Ampala, Salon. And Dr. Mosmi has more than 30 publications in reputed international journals. And she has attended many national and international conferences. And Dr. Mosmi area of interest are OCD, neuropsychiatry, community psychiatry, and the consultation license psychiatry. Dr. Mosmi, I welcome you for this this CME. And please take over the session and introduce the topic, Dr. Mosmi.
Yeah. Thank you, sir. A very good morning to all of you and all the PG residents who have logged in for this monthly All India webinar, courtesy the Sneka Hospital and East West Pharma. And it gives me great happiness to introduce today's speaker, Dr. Sneha Susan Verghese, who's also done her MD Psychiatry from NIMHANS, and then she went to Australia, Melbourne. Dr. Sneha will be speaking on the topic Orientation to EEG, a primer for postgraduate PG residents, like how it helps in psychiatry, EEG, in today's current times and current scenario. And I hope it will be a very good learning experience for all the residents who have logged in. And the moderators will also kindly continue to introduce the speaker. Thank you.
Thank you, ma'am. Thank you. Before introducing the speaker, so I have one announcement for all the participants. So throughout the course of presentation, the speaker will be asking 5 MCQs in between. So the participants who are answering first and second in the chat box will be taken as a winner, and the prizes and certificates will be issued before the next session. In the last session, there were 6 winners from Anterior Medical College, CMC Vellore, and NIMHANS. So all of them were given the certificates and the prizes until date. Now I will introduce Dr. Sneha. Dr. Sneha Susan Verghese completed MBBS and internship from Silver Jubilee Mission Medical College, Thrissur, Kerala. Did her MD Psychiatry from National Institute of Mental Health and Neurosciences, NIMHANS, Bangalore. Graduated as the best outgoing student of the batch and with the top honors in the psychotherapy program. A paper based on MD thesis work on catatonia was selected for oral presentation at European Congress of Psychiatry 2021. Currently working as a senior registrar in psychiatry at the Royal Melbourne Hospital, the Northwestern Mental Health, Australia. And she's my colleague when I was doing my residency in NIMHANS. So it's my great pleasure to introduce my colleague in this forum. Yeah, the online dais is yours, Dr. Sneha.
Thank you. Thank you, Nora.
Naveen, can we mute all of them except the speaker and the chairpersons?
Doctor, since so disturbance, I muted all. Doctor, kindly unmute, doctor.
Okay. Yes, Dr. Sneha, you can go ahead.
Yeah. Shall I share the screen now?
Can you be a bit more audible?
Yes, madam, you can share, ma'am.
Need to adjust the audio settings in your system.
Yeah. Let me just see. How is it now? Is it better?
Yeah.
Yeah.
If possible, you can speak a little louder. So that
Yes, yes, I will try. I'll try.
Thank you.
Thank you so much, everyone. It's a great privilege to present in this program with a session chaired by Professor Maushmi and organized by Dr. Paneerselvan and the moderators, Dr. Vivek and Dr. Nurul. I'll just share my screen now. So So before I start with my presentation, I should probably say that I'm not an expert in EEG. I don't have any additional training in EEG. However, as someone who has gone through the PG exam in the last few years, and I was also very fortunate to have some of the EEG experts teach me and mentor me in preparing this presentation. So that is the only credentials that I have to present this topic before all of you. So with that, let me start my presentation. I will try to keep it within 45 to 50 minutes. So I will be skipping through some of the theoretical aspects which we can all read, and I will be focusing on some of the concepts which we need to take a little bit time to understand. So with that introduction, let me move on to my presentation. So this will be the basic outline of my presentation. So first, an introduction. So with the introduction, we are going to talk about what exactly is an EEG. So EEG is nothing but a voltage versus time graph. All right. So we know how a graph is usually. There is a y-axis, x-axis. So we have the voltage on the y-axis and time on the x-axis. So this is basically what an EEG is. Now, it is the sum total of postsynaptic excitatory and inhibitory potentials modified by the intralaminar nucleus of thalamus. So we will leave those two portions of the definition to come back later, and it is recorded from the scalp. So this is the definition of what EEG is. Now, when we think about the place of EEG in modern psychiatry, we can see that in applied electrophysiology, we have both diagnostic and brain stimulation techniques. So in the therapeutic brain stimulation techniques, we have TMS, vagal nerve stimulation, and DBS, while in diagnostic techniques, we have mostly EEG and evoked potentials. So although historically, the initial application was for the detection of organic conditions, nowadays, EEG has come to be an interface with experimental neuroscience. Now, I will not talk much about this slide. Now, this here would be my first question for the day. Now, this person is an extremely important figure in the history of EEG, and I want to know who can recognize this person. If somebody can recognize without the options, that is great. Yeah, so I think we already have some answers here.
Yeah, the Hans Berger, the answer.
Yes.
The answer is Shamini, and second is Mohammad Abida.
Yes. So congratulations, guys. You're absolutely right. This is Professor Hans Berger. Now, in 1924, Dr. Hans Berger is the one who recorded the EEG first. However, it must be said that the notion or the concept of EEG was even there before that. In 1874, Richard Caton found that there was spontaneous activity from exposed animal cortices, but the first human EEG was done by Dr. Hans Berger. And any guesses on who was the subject of the first EEG? Any guesses in the chat box? All right, it is his own son. So Dr. Hans Berger did the first EEG on his own son, and he is the one who discovered alpha waves in EEG. And before Dr. Hans Berger, even though we knew that there was electrical activity in the brain, we didn't actually know from where this activity was coming from, whether it was from the vascular system, from the glial cells, or from the neurons. So it was Dr. Hans Berger who pinpointed that the EEG waveforms were coming, in fact, from the neurons. So moving on, let's go to some of the very basic principles. The reason why I'm saying this is without understanding these basic concepts, we cannot build up the foundation to understand EEG. So now let us talk about what exactly is voltage. Going back to high school physics, voltage is nothing but electrical potential. So it is basically like electrical pressure. So this is an example that we usually use for potential difference, right? Like the water tank is kept at the top of a tall building. So it has some potential energy in it. And the potential energy always is flows from a point A to point B. So voltage similarly always is a difference of electrical potential between point A and point B. Now, let's see what is current. Current is nothing but the number of charged particles or electrons flowing past a given point within a specified time. Now, what is resistance? Resistance is the inverse of conductance, as in the ability of a substance to keep the charged particles from passing. Now, we know that resistance is usually used for direct current, while we use the term impedance for alternating current. Now, let's talk about frequency. We are all familiar with the sine wave, right? Now, the frequency is the speed of an oscillation. So, it's usually given by the unit of hertz, which is the number of oscillations per second. And now we know that in a sine wave, this is the height of the wave is the amplitude. Now, what is power? Power is nothing but the and which is the square of the amplitude. So in EEG parlance, we are going to come across these terms very frequently, and it's important that we understand what each of these terms mean. Now, what is phase? Now, phase is the amount of synchronization across several generators. So to make it very simple, if we have a sine wave like this, a wave where the peaks coincide would be quite synchronous, and we would call them in phase. Now, if the waves were like this, if the waves were like this, and the other wave was like this, the peaks are not coinciding. So this is something that is known as out of phase. Now, the basic principle of EEG is that EEG is nothing but an extremely sensitive voltmeter. The unit of measurement here is microvolts. And with that, let's move on to see how it works as a voltmeter. So we know that the EEG waves are like these squiggly lines, right? So these brain wave reflects the transient difference in electrical potential. And I said that electrical potential is always measured between 2 points, A to B. So the points could either be, as shown in the first figure, on the scalp, or between 1 point on the scalp and a neutral one on an off-scalp location. So just keep in mind, it can be either 2 points on the scalp or 1 on the scalp and 1 at an off-scalp location. Now let us talk about from where this electrical activity is coming from. So in order to make this a little more easier to understand, I think it will be helpful if we take the help of a few diagrams. Now, forgive my drawing skills, it's not that great, but here what we have is a pyramidal cell. Now, we know that pyramidal cells are mostly concentrated in the layer 5 of the cerebral cortex, right? And each neuron, we know that the electrical activity can be a resting membrane potential, an action potential, and we do have post-synaptic potential in the terms of excitatory post-synaptic potentials and inhibitory post-synaptic potential. Now let us see, this is a synaptic cleft. Let us see what happens when an action potential gets here. What happens if it is an action potential gets here, and for an excitatory post-synaptic potential, we have to know that there is an influx of positive charges inside. And what happens? There is negativity outside. So at the other end of the neuron, there is reverse of this happening. So there would be positivity outside and negativity inside. Now this is an EPSP. Now, considering an inhibitory post-synaptic potential, what would happen is, instead of the depolarization, what's going to happen is the hyperpolarization. So you're going to have negativity inside and positivity outside the cell. And similarly, across the neuron, you're going to have positive charges inside and negative charges outside. Now, if you look at this, you can see that there is a separation of charges here. So there will be flow of current from the positive source to a negative sink, and that leads to the development of a dipole. And when there is a dipole like this towards the surface of the cortical layers, an electrode placed near the scalp can pick this up. So one important point to note here is that whenever there is surface positivity, the deflection on the EEG is going to be a downward deflection. It might come across as a counterintuitive one, not what we would regularly think, but this is just a conventional method of how the deflection looks like. If there is surface negativity, the deflection on the EEG is going to be upwards. Now that we have looked at how that electrical activity is happening in a single neuron, we know that although EEG is quite sensitive, it is not that sensitive enough to pick up the electrical activity from a single neuron. We need the synchronized activity of a large number of neurons to produce an electrical activity that can be picked up by EEG. So imagine an audience clapping. If a few people clap here and there, we are not going to hear that sound properly. Or imagine if a few people clap first and then a few others start clapping later, even then it's not going to be that great. But if the whole audience claps along as one and everyone does that at the same time, then we are going to have a very good quality of the sound. So similarly, the neurons have to be firing together at the same time, and also the orientation matters. For example, let us see this another picture. If this is the cross-section of a brain, imagine this is the cross-section of a brain, and there are sulci and gyri, and we have neurons oriented in this manner. What happens is these charges get neutralized. They get cancelled out. So there is no conductance of the electrical charges towards the surface through the various, the dura mater and the skin. So it does not get transmitted. But instead, consider this arrangement. When there is a parallel arrangement of neurons, what happens is the EPSP and the IPSP get added up. And that creates a potential which can be picked up by the surface electrode. So that brings an end to what I wanted to say about how this electrical activity is produced. Now, this is just this slide is just the explanation of what we have just discussed. So I'm going to skip that. Again, the one thing that I want to mention from this slide is that the generation of the extracellular voltage fields is usually from the axons from the thalamus. So the intranulnar nucleus of thalamus has a very crucial role in generating these voltage fields. Now, moving on to some of the practical aspects of how to do an EEG. Now, we know that there are two kinds of electrodes, basically the wet electrode and the dry electrode. The wet electrode is nothing but, there is this metal disc that connects to the skin via a conducting gel or paste, so that the electrode, skin, and the electrode gel that functions as a capacitor that attenuates the transmission of low frequencies, while the dry electrode just makes direct contact with the skin. Now, the most commonly used materials for electrodes are the silver and silver chloride. Sometimes even gold and platinum can be used. Now, coming to the electrode impedance, and impedance is nothing but the resistance. It's measured in ohm. All the dead skin, sebum, and sweat can lead to an increase in the impedance. So in order to lower the impedance, our aim is to keep the impedance less than 5 kilo ohms. We need to wash and dry the hair, no hair products, apply the electrode gel, clean all the electrode sites with alcohol. These are some of the steps that we take to reduce the electrode impedance. Now, coming to the 10-20 international system. With the 10-20 international system, again, it's developed by Herbert Jasper. In order to to like properly understand this, because this was a very confusing area for me as well. So what helped me was again taking the help of a diagram. Now, imagine that we are looking at a person's head from above. The person is in a supine position. So we mark 4 points. So one is the nasion and the inion at the occipital protuberance, and 2 preauricular points here. Now we are going to join the nasion to inion anterior posteriorly. We are going to make a transverse line between the 2 preauricular points. Now what we are going to do is, this is what it gives its name of the 10-20 system. We are going to measure the anterior posterior distance, and we are going to say measure 10% here of the anterior posterior distance, 20%, 20%, 20, 20, 10. Similarly, we are going to do 10 in the transverse direction, 10% here, 20, 20. So this was 20, 20, 10, 20, 20, 10. Now what we are going to 20, 20, again 20, 20, 10, 20, 20, 20. Now, parasagittally, we are going to draw a line, 2 lines. We are going to mark it 25, 25. We are going to join these portions like these. So what we are going to end up is a grid-like diagram, which looks somewhat like this. Now, to name the electrodes, there are some basic rules that we have to follow. So the first rule is that the electrode placements are named with both letters and numbers. Now, the letters stand for what is the underlying brain region. So we have F for frontal, C for central, P for parietal, T for temporal, and O for occipital. And then there is numbering. The one rule to note is that the numbers are odd numbers on the left side of the brain and even numbers on the right side. So if this is left, this is right. The midline we'll call 0. So this will be the ZZ. So this will be C3, C7, and this would be PZ, FZ, FP1, FP2. So this would be O1, O2, 7. So if you look at the way that this electrodes are marked, you can see another rule that if you move away from the midline, the numbers increase. Yes. So C3 is here. Sorry, this should have been even number. So let's go back to this picture here. If you look at this, you can see that as you move away from the midline, this is the right side, this is the left side. The letters stand for the underlying brain region, and the numbers, even numbers on the right, odd numbers on the left. And as you move away from the midline, the numbers increase, in their value. So this is basically the 10-20 international system. Now, sorry. Yeah. What are the advantages of this 10-20 international system? So basically, it makes it comparable between the different laboratories, that we know the electrodes overlie the same cortical regions despite the differences in head size. So this is why this is the currently accepted system that is used almost all over the world. Now, there are different new inventions which make this electrode placement much easier. And one of them is an electrode cap, so that instead of placing each electrode separately, you can just place the cap on the head. Now that we have understood what is an electrode, how is it placed, let's understand how they are connected, because this is extremely important. The way the electrode pairs are arranged for recording is what we call a montage. Now, usually in EEGs, we do have mostly two kind of montages. One is the bipolar montage. The other one is the monopolar, or what we call the reference montage. And the bipolar one is again divided into the anterior posterior one and the transverse one. So let's look at the bipolar montage. Now, the electrodes in a bipolar montage are referenced from one scalp location to an adjacent scalp location in chains of electrodes across the head from front to back or left to right. So that's what I was talking about, the longitudinal or the transverse or in a circumferential pattern. Now, this is the bipolar montage. Now, if you look at it, you can see that we are going from, I'm not sure if this is visible enough. So here is the 1020 international system. We are looking at the head from above, as I showed in the last diagram. Now we are going to connect these electrodes from FP1 to F7, F7 to T3, T5 to T3 to T5, T5 to O1. And again, this another chain. So this is a channel when we connect two electrodes, and a group of, when we connect the channels in a longitudinal fashion, that is what makes it a chain. So here we have a transverse bipolar montage where we connect the electrodes. Again, if you look at it, the electrode placements are the same. It's just the connections that differ. Now, I think it's time for another question here. Who can tell me, once you look at this bipolar montage, the anteroposterior one, what is the common name that we use for such a montage? I can give a clue. If you can look at the shape, that would give us a clue for what is the common name for a bipolar montage that is arranged in this manner. Yep, absolutely. That's absolutely true. It's a double banana.
Yeah. So banana, can we take it as a right answer, or double banana will take?
Double banana will take.
Okay.
Yeah. So you guys are doing it even without any options, like even without giving the multiple choices. So yeah, let's move on. All right. So now let us see how. So we were just dealing with theoretical concepts until now. Now let's see. If someone brings us to an actual EEG and ask us to look at it, what we find is what we see on this slide. Okay, so the first thing that we have to look at is what is the montage. How do we find that out? So if you look at this, remember how we made the connections in the bipolar montage, anteroposterior bipolar double banana montage? We started with FP1, F7, T7, P7, O1. Yeah. Now look here on the epoch, EEG epoch, FP1 to F7, F7 to T7, T7 to P7, P7 to O1. So this is exactly what we have done here. If you look at the next series of the EEG, then that is again FP1 to F3, F3 to C3, C3 to P3, P3 to O1. So there is another rule that we can find from here, which is that, sorry. Yeah, the anterior electrodes are displayed on the top before the posterior placed electrodes, and the left side electrodes, odd numbers, are displayed at the top before the right side electrodes. So this is exactly how it is. You can see that the odd numbers, left, odd, are placed above, and frontal to occipital, anterior to posterior. So this is again like some of the basic rules that we can follow to help us read the EEG better. Now coming to the transverse bipolar montage, again, if you look at, this is how we mentioned FP1 to FZ to FP2, FP1, FZ, FZ, FP2. And this is another chain that we can make. This is this chain, and there is this long transverse chain. this change. So just by looking at the EEG epochs, now we are able to identify whether it's an anterior posterior montage or a transverse bipolar montage. Now there is something also known as a referential montage. Referential montage means the electrodes are referenced as single common reference point. So most commonly, it is earlobe, mastoid prominence, or the midline structures. Now, this is an example of an ipsilateral mastoid referential montage. This is a contralateral mastoid reference montage, which is kind of self-explanatory from the picture. Now, there are reference-free montages as well, but we'll probably not get into this at this point. Now, I want you to have a look at this picture. This is taken from CTP. So if you look at this, you can see that there is a clear difference between the central and the occipital, the channels. However, when we just rearrange how they're connected, when we change the montage, you can see that even with the same electrodes, just by EEG pattern looks. So I just wanted to bring it to your notice that the montages do matter. Now we have looked at electrodes, electrode placements, electrode arrangements, montages, and now let's have a look at how we are able to pick up the EEG activity from this background noise of all the other electrical activity that's happening in our body. Now, this is what an EEG amplifier does. Now, this is a game that we all have played in our, primary school years, spotting the difference. If there are two pictures like this, and we are asked to spot the difference, we could easily do it, right? So, similarly, an EEG amplifier picks out the differences between the what is given between two electrodes. Now, let's see an example. So this is input 1, this is input 2. Between the input 1 and input 2, it's very clearly seen that this is the different part. So when you put those two inputs through a differential amplifier, the output that we get is just the difference. And this concept or this principle is the common mode rejection ratio. The reason why I want to talk about this is to talk about the polarity rules, because that is important when we come to reading an EEG. Now, with the polarity rules, we mentioned that when there is surface negativity, the deflection is upwards. When there is surface positivity, the deflection is downwards. Now, let us see based on the input and output, between the two different electrodes. For example, here there is input 1 and here there is input 2. So if the input 1 is negative with respect to input 2, we are going to get a positive deflection. Now, if input 1 is positive with respect to input 2, we are going to get a negative deflection. Now, this can be quite confusing because it goes against what we naturally assume. So this example that I've used previously is, imagine, somebody's lifespan. If they started from a negative position in their life, like as someone living on the streets, and they've made up to a higher position later on as a CEO of a big company, they have gone up, right? So starting from negative, going towards positive would be an upward deflection. Starting at a very high position in life and then ending up on the streets, that would be a negative deflection. So if the input 1 is positive with respect to input 2, then you're going to get a downward deflection. Now, the reason why this is important is we are going to come across these deflections when we try to read an EEG. Now, in T1, there is an underlying tumor. Imagine that there is an underlying tumor at the area T1. Now, T1, and consider F7 here. And Okay, let's consider F7 to T1 and T1 to T3. So since T1 is negative, because we know that let's see how we'll find out whether T1 is negative here. Now, if you look at this particular pair of electrodes, we can see that F7 to T1 is a negative deflection. Now, going by what I said just before, if you go from a positive to negative place, then it's going to be a negative deflection. So here in this manner, it would be F7 would be positive, T1 would be negative. Now, if you look at T1 to T3, it's an upward deflection. So that means it started from somewhere negative and ended up somewhere positive. So T1 would be negative and T3 would be positive. So if you take both of these channels together, the commonality is that T1 is negative. So this kind of brings us to an understanding that there is underlying surface negativity at the point of T1. And usually when there is, a mass in there, intracranial mass in there, then that leads to that surface negativity. Now, just to see if you have understood that concept, who wants to guess what would be the charge at T3 with what is given here? Any answers in the chat? Yep, absolutely. Negative is the answer. Because it couldn't have been easier to answer, because here T3 reference, it's an upward deflection, and upward, I said, is always negative in EEG parlance. So negative is the answer. Yeah, shall we move on? Yeah, now coming to something known as the frequency filters. I know that I'm running out of time, but again, this is important, because unless we realize what filter is on, the EEG is going to look very different. So let's quickly talk about filters. Now, the low frequency filter is when, imagine like keeping a physical filter, okay? That helps in understanding. If you keep a physical filter at 1 Hertz, what's going to happen is anything less than that is filtered out, and any frequency that is higher than that is going to be passed through. So a low frequency filter is also known as a high pass filter. Now, if it is a high frequency filter, we are going to keep the filter at a higher frequency. So what happens is all the frequency above that is going to be cut out, and anything less than that, the lower frequencies are going to be passed through. So it is a low pass filter. Yeah. Now let us look at some of the EEG. Now here we have a low frequency filter kept at 1 Hertz. And here we have a low frequency filter kept at 5 Hertz. So anything more than 5 Hertz, here, whatever was more than 1 Hertz was passed through, but here only those frequencies which are more than 5 Hertz were passed through. So you can see how different the EEG looks just by changing the filter. Now look at the high frequency filter. Here we have kept a high frequency filter of 70. So anything more than that was not passed through, while all the frequencies less than that was passed through. But when the high frequency filter was switched off, we can see that there are all these high frequency myogenic artifacts that came in. So this helps us in kind of filtering through some of the artifacts. And it's very important that we actually look at the filter setting at the beginning before we start interpreting that, oh my God, there are so many artifacts in here. Now, this is something very similar. Nnotch filter is nothing but a filter that is set at 60 Hertz. So basically, the concept is that when some electrical appliances are plugged into the wall, they kind of give off some frequency. And when we are doing the EEG, that can interfere. So that if if the impedance of all the electrodes it's equal, it's not a problem. It doesn't come, it just cancels out with all the but if the impedance of one of the electrodes is kind of low, or if it doesn't match with the other impedance, what happens is that our AC current, India 50 hertz, that 50 hertz is going to come through this. So passing through this differential amplifier, the output is going to be that 50 hertz of contamination. So when we have the filter, that 50 hertz is filtered off. But when we switch off that filter, we can see that that 50 hertz of contamination is creeping in. So this is something, and again, talking about sensitivity is nothing but, the amplitude. For example, if it is a 40 microvolt, and if you're going to keep the sensitivity at 7, then we can see that the height becomes 6 millimeter. If you're going to reduce the sensitivity, you're going to get taller waves. If you're going to increase the sensitivity, you're going to get smaller waves. So unless we know what the sensitivity is kept as in an EEG reading, we'll be making low voltage. So that's why we need to look at all these before we make an interpretation. Now, the EEG recording and methodology, I'm not going to go into that in detail. So I can share the slides if you need, because the EEG, how it is taken in different laboratories, and this is the procedure that we usually follow at the Center for Brain.
Sneha, can you unmute?
Oops, sorry. Like, where did I lose mine?
Yeah, the last slide.
Yeah. So I was just saying that I'm going to skip through the slides because the procedure of taking the EEG could be very site specific, but this is just the general idea of how we do it. Now, EEG specifically in psychiatric patients can be very challenging because one, we are dealing with disturbed patients. There could be tardive dyskinesia and akathisia, and muscle activity itself produces changes in electrical activity, and sedation is not acceptable, and there could be prolonged recording time. So those are all the caveats of doing EEG in psychiatric patients. Now, coming to the latter half of my presentation of the basics of EEG interpretation, because this is in itself a language in itself. So there was this one question that I want to ask, which is the bare essential of interpreting an EEG. And that question is, I'm going to make it a little tricky. What is the frequency bandwidth of a burger rhythm? So if I had put it in a different way, I'm sure that you would all be answering very quickly. So, yep, that is correct. 8 to 13 is the correct answer because burger rhythm is nothing but your alpha rhythm. Congratulations. So these are the normal intrinsic frequencies. We are all familiar with this, so I'm not going to spend too much time on it. The gamma, beta, alpha, theta, and delta. Delta, again, I'm going to skip through these slides because this is again very much of theory. It's just that we need to know that, this is how you measure. There is that 1 second in the EEG epoch. We are going to measure the number of peaks, and that is how we come to the, the frequency. Theta, hippocampus, delta, slowest, stage 3, slow wave sleep. What else is there? Alpha, again, burger rhythm. So alpha or the burger rhythm is predominantly normal closed eye waking EEG. So relaxation or minimal mental activity called as the idling brain. So alpha, if you can measure that 1 second, you can see that the number of peaks would be 8 to 13. And one important point is that it is more in the posterior cortex or the occipital region. So that is why it is also known as posterior dominant rhythm. And it is abolished by eye opening and disappears in sleep. So even if you open your eyes or you fall back to proper sleep, it goes away. It's only there when your eyes are closed and you're relaxed and kind of idling. And this is very important, the alpha reactivity. So before we get into this, you can see that how it says eyes closed, eyes open. But how can we make that out? If you can see here, this is your alpha activity, okay? 1 second, and they're like 18 to 13 hertz activity here. So this alpha rhythm disappears when the eyes are open. But how can we make out, whether this is eyes closed and eyes open? So the one thing to do is to understand that in our eye, cornea is more positive compared to retina, which is more negative. So when this is the eyelid, which is, which goes like this in front of our eyes. And when the eyelids are closed, what happens is our eyeball goes upwards, which is nothing but our Bell's phenomenon. So when the eyeball goes up, there is the, FP1 or the FP2 electrode up here on the top. So that positivity goes there. And positivity, we know, is a negative or downward deflection. So here you have this downward deflection in the FP1 area here. So this shows that the eyes are being closed. So in the opposite manner, when there is an upward deflection, the eyes are open. So when in the middle of the space, when the eyes are opened, we are losing the alpha rhythm. And this phenomenon is called the alpha reactivity. So the characteristic of alpha, again, frequency, amplitude, reactivity. That is something that we need to mention when we are interpreting an EEG. Occipital maximal, usually right side more than left. Now, beta waveforms, we know more than 13 hertz, dominant frequency in normal adult waking EEG, mirror neuron system along the motor strip, typically seen in alertness. Now, this is the beta rhythm. So you can see that there is actually excessive beta activity. So this is someone who is on clonazepam for anxiety. So that is why that alertness level is quite high in this patient. Now, gamma, again, the black holes of EEG, we don't really know much about it, but it is at the forefront of EEG research, especially in schizophrenia. Now, there are some normal variants. Now, activation procedures. This is also something that I need to mention before we wind up. When we do hyperventilation, there is decreased carbon dioxide concentration. So vasoconstriction happens. There is relative cerebral ischemia. So at that time, there is increase of slow waves. Now this is hyperventilation. Now if you can see this, there is diffuse theta and delta slowing after vigorous hyperventilation. So around at this point where the blue line starts, you can see that slowing happens. Now, photic driving. What is photic driving? I'm not sure if you can see this, but here you can see small red lines more closely spaced together here, even more closely spaced together here. And time locked with that, there are these potentials. So that is, photic stimulation is nothing but we are like flashing lights to the patient. Now, EEG artifacts. What are EEG artifacts? They are signals recorded on the EEG which were not generated by the brain. They can obscure or alter the EEG pattern, so and that can confuse us. There are lots of EEG artifacts, both physiological and non-physiological. We'll just go through them quickly. This is what happens when someone's chewing when an EEG is done. So that's a periodic pattern, repetitive chewing motion. Now, this is an EKG artifact. How do we know that it's an EKG artifact? Because if you look at the ECG recording at the bottom, you can see that time locked with the QRS. With every QRS, there is a potential. So that's how we know that it's an ECG artifact. Now, eye blink artifact, I just mentioned how that corneal positivity causes a downward deflection. And that's how we know what's an eye blink artifact. Then eyelid flutter, lateral eye movements, lack of time. We are not going to go through this. Now this checkboard muscle artifact form is by the tooth grinding that happens. This is a muscle artifact or the myogenic artifact where there is high frequency artifact. Respiratory artifact where you can see like wherever the black arrows are, if you can see the patient's chest movement, you can see that that coincides with that. There is the shiver artifact here. Glossokinetic is nothing but the movement of the tongue because the tip of the tongue is negative. Then this is the 60 hertz artifact that I was talking about. Yeah. Now this is when there is a faulty electrode. You get a mirror image, and you know that, if you look at, then that's how you realize that's a faulty. This is the sweat drift artifact. Now, very quickly, because we are almost to the end of the presentation, EEG normal sleep, because it's something that could be important in the examination. Before we go to the normal sleep, let's have a quick look at the normal awake EEG. Now, how do we know that this is a normal awake EEG? There are three main clues. One is that you can see a lot of high frequency activity here, which is the myogenic artifact. When we are awake, obviously we are going to move some of our muscles. And here in the corner, you can see that there is an eye movement artifact. And you can see that in the posterior electrodes, you can see alpha rhythm. So these are kind of the three things: myogenic artifacts, the PDR, posterior dominant rhythm, and the eye movement artifacts. Now, let's look at the normal. Is that in the posterior leads, there is an absence of PDR, no alpha. Then here in the vertical boxes, you have what you call the slow moving, because you can see the EEG lines moving apart, coming together, moving apart, coming together. This is, moving apart and then coming together, then again moving apart, coming together. So this is what is known as a slow roving eye movements. Again, the exact mechanism will take time, so we'll not go into that. Then something known as, here if you can see some positive deflections here. So these are the positive sharp transients of sleep, or known as pause. So the pause are here. And if you look here at these central electrodes, you can see that there are these vertex waves which are kind of, out of phase with each other. So vertex waves, pause, and absence of alpha with slow roving eye movements. That is stage 1. Stage 2 is the K complex and sleep spindles. K complex and sleep spindles. So these are diffuse high voltage slow potentials, and sleep spindles follow the K complex. So that is about the stage 2 sleep. And slow wave sleep is again diffuse delta activity. Now coming to REM sleep. REM sleep is again, how do you differentiate between REM sleep and awake state? You can see that here the myogenic artifacts are not there. PDR is not there. There is no alpha rhythm. Because when you go to sleep, the alpha rhythm goes away. And when you are in REM sleep, there is no muscle activity. So, yeah. So polysomnography is an applied field in which the EEG in sleep is utilized. I'm not going to go into that. Again, a summary slide of EEG in sleep. Some of the developmental changes in EEG, again, I'm not going into that in deep. I can share the slides, mostly theoretical aspects. Some of the abnormal EEGs, I'm just touching on this because we are not really expected to interpret an EEG that is primarily the neurologist domain, but we need to know about what are the abnormal characteristics. So just, to understand what is a spike. So spike is nothing but this is a spike. It's a very sharp in contour, steeper rise than decline, 20 to 70 milliseconds. Then there is the polyspikes, which is a series of spikes occurring before the slow wave. Spike and wave complex is there. So there is a spike and the accompanying slow wave. And then there's a sharp wave, which is again very similar to a spike, but more prolonged, duration of 70 to 200 milliseconds. Now again, these are showing occipital spikes. Now this brings us to the last question of the session. Interpret this particular EEG. It's a 7-year-old boy with staring spells. Anyone wants to give it a try?
Yep.
Yep, I think we are.
A couple of people answered in the chat box.
Yeah. That is absentitious. So you get the 3 Hz spike and wave pattern. See, this is 1 second. I'm not sure if you can see this, these purple lines demarcating each second. So if you count the spike and wave, you can see that it's 3 Hz. 1, 2, 3. Yeah, and that's the characteristic pattern of absentitious. So from my own and my colleagues' experience in going through psychiatry final year MD exam, the examiners do not expect you to be an expert at EEG interpretation. But if you can identify some of the basics of how to read an EEG and some of these very characteristic EEG patterns from an examination point of view, that is usually more than enough. So these are some of the epileptiform discharges. Again, there can be rhythmic patterns, periodic patterns. I don't think that we need to go into those in details, but if someone asks us to interpret an EEG, it is always good to have these terms in mind, whether they are awake, whether they have a well-formed posterior dominant rhythm or alpha rhythm that attenuates with eye opening, whether they have a normal anteroposterior gradient where the anterior frequencies are faster and lower in amplitude, and in the sleep area, whether there are distinct sleep states with specific sleep structures. So whether there is diffuse slowing in the background, whether there is focal slowing. So slowing is in PDR of 8.5 Hertz or less is abnormal. Whether there is focal slowing, focal attenuation. So these are some of the things that we can keep in mind and use in how we interpret the EEG. And indications in psychiatry are late onset psychosis, refractory behavioral problems, first episode schizophrenia after the 4th decade, QEEG, which is now a developing field in delirium, dementia, and depression, cognitive and developmental disorders, substance abuse, and behavioral disorders. So each of those are like separate seminars on its own. But since my topic today was a primer of EEG for postgraduates, I thought that we would stick to the basics of ECG and how we can attempt even reading an EEG when given for exam. So this is a summary slide. We went through the history of EEG, that the mechanism, summated potential. We went through the EEG apparatus of the electrode, amplifier, EEG positioning system, 1020 system. Went through the montages. And some of the
Sneha, can you unmute?
Oh, I'm sorry. I don't know why that kept happening.
Yeah, the mute all option you applied. So only.
Okay. Okay. So yeah, so I need to thank these people because as I mentioned earlier, I'm not an expert in EEG, but it's with the guidance and teaching of Professor John P. John, Dr. Thomas Grigor, and Dr. K. Rakhavendra that I was able to make this presentation and get an understanding of the basics. Thank you so much.
Thank you. Thank you. Maushmi madam, so from your side, can share the comments and
yeah, lovely, very inspiring, I should say, presentation with a lot of novelties, and you kept us glued to our chairs. People at home were also looking at electrical people, the engineering types. Yeah. So it's very nice. Phase reversal, the importance is not given nowadays that much, isn't it? Could you just say 2 lines on that?
The phase reversal, what I understood is that it can kind of help in identifying, localizing things. But since we have so many other, more specific CT, MRI, which would give us better spatial resolution, I don't think that as such is quite useful
Yeah,
these days.
yeah.
Nurul, can I get any question from the audience?
Yes, sir, we will.
In chat box, any questions from the audience?
I think since we have discussed the primer part, so we will be arranging the other proper interpretation part from the other experts, sir. So we will conclude the session with the explanation. I will by telling the winners of the questions, sir. Hello, sir.
Yeah.
Hello. Yeah. Any questions from the participants which is pertaining to the current presentation? They can ask, they can unmute themselves and ask, or they can share their question in the chat box. And that should be pertaining to the today's presentation. Yeah, so one comment from the audience. Can you cover the remaining things in part 2 of this topic? Yeah, hopefully. And thanks for the appreciation. There are no much questions in the chat box. Yes, Dr. Sneha, thank you very much for accepting our invite and to deliver a great presentation in the basics of EEG. Apart from whatever we have discussed as an indication for EEG, so apart from that, we have comorbid epilepsy patients, so that we need to take care of. So during that time, psychiatrists ourselves can order the EEG. And second thing, before a clozapine patient who is at a particular dose going for a seizure, so if you want to clearly monitor the side effects related to clozapine in terms of seizure, we can periodically take a EEG once in 6 months, once in 3 months, or whenever we are building up the dose. So there, psychiatrists can effectively use a EEG to pick up the yearly kind of seizure signs in the patient. Second thing, we are dealing with so much of the neuropsychiatric cases there, psychiatrists themselves can order the EEG, and other is the dissociative disorder. There also we can, from our side, we can order the EEG instead of requesting the neurologist to comment upon and then order the EEG. And we know there are many psychiatrists who are our seniors, who are very well versed in EEG. They can themselves interpret the EEG. So that kind of demand of knowledge is much expected from the psychiatrist setting also. So now I tell the winners of the today's session. Number one, Dr. Shamini, Dr. Abhita, Dr. Srini Prakash for the first question, and Dr. Kanagalakshmi and Kalai Selvi, Kanaga Mahalakshmi and Kalai Selvi, and for the third one, Kalai Selvi and Srini Prakash on the and the fourth one, Kalai Selvi and Shamini, and the fifth one, Kalai Selvi and Vinayak Hegde. So these are totally 11 winners. So hopefully we'll deliver all the prizes before the upcoming session. And since the session went very well and more interesting, so we plan to have another session specifically on the basics of interpretation of EEG for the postgraduate residents. Hopefully we'll do in the upcoming session in the March. Yes, sir. Pani sir, from your side.
Yeah, thank you, Dr. Nurul. The congratulations for the winners. Almost 11 person has won these questions. Thank you, Dr. Chusan, for your wonderful and very informative presentation. More than 200 participants there till the end of your presentations. I thank Dr. Mosmi from Jipner Pondicherry for sparing your valuable time to share this session for especially this Sunday. And also I thank my junior psychiatrist, Dr. Nurul Hassan, for helping me to successfully conduct this Evolve series. And also all the participants for patient listening and discussion. That YouTube link is available. If any postgraduates want, you can get it from the West Pharma. The many people there in the chat box, they ask for the sharing the slides. I think you can request Dr. Susan to share the slide to Nurul, so that anybody want, you can contact Dr. Nurul, and Nurul will share the slides to you. And the next session will be, because we are conducting our Tamil Nadu PGCME on this February. On this occasion, I welcome all the postgraduates to come and join our Tamil Nadu State PGCME on the last week of February. That is February 25 and 26. So I welcome you all to join this PGCME. We have selected a very useful topic, especially for the focus or exam-oriented topic for our Tamil Nadu PGCME, and most of the speakers are very eminent people. So I request you all people to join and come and join for our Tamil Nadu PGCME. So thank you very much. And we have next, because the February month we are organizing our state PGCME. We'll have our next Evolve CME on the March month on 26th. So 26th of March month, where we will have continue our Evolve CME. That is for every fourth Sunday. Please and come and join this the Evolve CME. That is our 8th CME on 24th March. Thank you very much. And my special thanks to the sponsor of West Pharma. So thank you, West Pharma, for sponsoring our programs, Evolve programs, for successfully conducting our this program successively, consecutive success there in this Evolve webinar programs. So I conclude this session, and I request West Pharma to give a word of thanks.
Yes, sir.
Thank you, Doctor.
One thing, sir. As a continuation of this session, we will share the slides from the speaker. And second thing, for further reading, consider reading the EEG primer by Rowan. And we have a couple of notes from Dr. JPJ and other good people. So for exams, that notes also we will share to Naveen. From Naveen, it will be shared to the postgraduates.
Thank you, sir. Thank you so much for giving opportunity. First of all, I need to thanks to Dr. Panniselvan sir from Sneha Mindcare, and consistently is organizing the program, and also the coordination is gratefully given by Dr. Noor Lasan sir. And also my hearty thanks to Dr. Sneha Varghese ma'am, has given wonderful lecture for our postgraduates, and it is a pan-India program. So almost 215 participants has been benefited of your session, madam. And my thanks for Madam Oshini ma'am for this wonderful session, and the session will be continued with the help of this program for the benefit of our PGs. Once again, thanks to all. Have a nice day and happy weekend.
Thank you.
Thank you.
Thank you, Sneha. Thank you, Moshi madam.
Thank you, Susan. Thank you for your wonderful lectures.
Thank
There
you,
are
sir.
more than 200 participants from across India have joined. Many people from North India has also joined. I think some people from Orissa and Kolkata also somebody has joined. We have a concurrent, one more program was there in Tamil Nadu, that Mandhan program. In spite of that, a lot of people from Tamil Nadu also joined these programs. Thank you very much.
Thank you.
Thank you, sister. Thank you very much.